is going to present on minimally invasive strabismus surgery versus conventional approach for inferior oblique recessions.
So, good evening, members of the jury and everyone present here. As we all know, this is the era of minimally invasive surgery across all surgical specialties, not just ophthalmology. Minimally invasive surgery is gaining so much popularity in recent times because it entails a small scar, gives the patient a better cosmesis, there is reduced patient discomfort, and as a result of which the patient recovers early, and that's beneficial for all of us. As far as the field of strabismology goes, the concept of minimally invasive surgery in this was introduced first by Dr. Daniel S. Mojon in 2007. Initially it was for horizontal recti for recession and plication, and afterwards a number of studies were done comparing conventional modalities with recession and plication of recti, and all of them found MISS to be as beneficial as conventional techniques in terms of outcomes, while also providing better cosmesis. The same cannot be said for inferior oblique recession. Even though Dr. Mojon introduced it in 2009, not a lot of studies have been done since then comparing MISS techniques for inferior oblique recession with the conventional ones, like the fornix-based incision, which brings us back to our topic. We, in this study, have compared minimally invasive strabismus surgery with the conventional technique, by which I mean a fornix-based incision for inferior oblique recession. This was a prospective study conducted at Guru Nanak Eye Center in New Delhi. Why is inferior oblique recession important? Because it's a fairly prevalent problem. It's associated with 70% patients with esotropia and 30% with exotropia. It can be of two types, both primary as secondary, and recession has been found to be one of the most effective procedures to correct the eye overaction. As I've already covered, numerous studies have covered the comparison of MISS for conventional surgery versus horizontal recti, and they have found MISS to be favorable, and which brings us to the rationale behind our current study, where we are comparing MISS for inferior oblique with the conventional technique. We included adult patients in our study, 40 of them who were aged 18 years and above, and they with both primary or secondary eye overaction. Horizontal muscle surgery was required in a majority of these patients, keeping patient satisfaction in mind, and it was done as a single stage procedure. We excluded patients of prior IO surgery and who were requiring other vertical surgery instead of inferior oblique. We divided the patients into two groups. Group C was the control group where we performed the fornix-based incision surgery, and Group M was the group where we performed MISS. Basic history concerning strabismus was taken. An examination entailed best corrected visual acuity, anterior segment examination, and proper deviation assessment. We quantified the inferior oblique overaction using vertical prisms by measuring the hypertropia of the adducted eye, which was graded as per the reference which I have mentioned below. Pattern strabismus was also noted and quantified accordingly. This is a quick video of the surgical technique. I'll just skip to the part where we have made like a little keyhole incision. This is how the tenons is dissected, and a keyhole incision has been made. After it has been made, it looks somewhat like this, and the IO can be accessed directly through it without the need for a full-sized fornix incision. It can be hooked, and we followed the Park's technique of recession in this, where we took the insertion of the lateral rectus as the landmark, and depending on the amount of insertion required, we hitched the muscle stump below and lateral to the LR insertion. So the post-operative follow-up was done on the first post-operative day at 1 week and at 1.5 months. The cosmetic parameters we undertook were conjunctival injection and chemosis, which were graded according to the references I've shown, and periorbital edema as well. Eye overaction was measured in the post-operative period, just how it was measured in the pre-operative period as well. Coming to our results, our mean age group was comparable in both these groups, and also the sex distribution was comparable. There was no significant difference. There was a significant difference, however, in the pre-operative diagnoses which we included. So a total of 19 patients in Group C, which was the control group, had primary eye overaction, and 1 patient has secondary, which was a case of superior oblique palsy. And in Group M, there were 13 patients who had primary overaction and 7 with secondary. However, even though such disparity in terms of our patient selection, we did not find a significant difference in the preoperative IO overaction between the two groups, for which the p-value came out to be 0.321. Similarly, there was no difference in the dose of IO recession which was done in the two groups and the final correction obtained. I'll just
Directly to
quickly
the
complete
conclusion
this.
part.
Yeah.
Time is over.
Just to quickly go through this, we found a favorable result in terms of the cosmetic parameters in the MISS group across all three parameters, both for conjunctival injection, for chemosis, and also for periorbital edema.
Move to the conclusion slide. Time over.
Yeah. So after surgery, we have found that MISS for IO recession is as effective as a conventional technique, while it offers better cosmesis and reduces patient discomfort in the early postoperative period. So our recommendation is that it can be accepted as a surgical modality according to surgeon preference and skill. Thank you for your patience.
Was it a randomized control trial or?
Yes, ma'am, this was a randomized control trial.
What is the definition?
And what was your incision size basically when you declare it as minimally invasive?
Ma'am, it was a keyhole incision, and it has been called in literature as a keyhole incision, and we tried to keep the size to 2 by 2 mm of the incision.
Since we had to rush through your presentation, just in very short, which were the outcome parameters you compared? Which were the outcome parameters you compared between the two groups?
Ma'am, our primary outcome measures were the cosmetic parameters, which we talked about, chemosis, conjunctival injection, and periorbital edema, and also the postoperative alignment. The postoperative alignment was comparable between our two groups, but we found a significant difference in the immediate postoperative period in the MISS group in terms of the cosmetic parameters, which was maintained up to 1 week after the surgery, but at around 1.5 months, both the groups were comparable. There was no significant difference at that time.
You did not use any conjunctival sutures for closure.
For the keyhole incision, we required just a single absorbable vicryl suture, just one suture. But for the fornix incision, we required multiple, around 4 or 5 sutures. Thank you.
But it was a nice presentation, but you should always keep in mind that it's a competitive session.
Yes,
And
sir.
overshooting the time will deduct your marks.
Yes, sir.
Okay, thank you.
Thank you.
Can we go to the next presenter?
So the next speaker is Basa Umar Reddy. She will be speaking on partial modified NEPs to the rescue of the congenital third nerve palsy.
Good evening everyone. I'm Dr. Varsha and I'm going to speak about congenital third nerve palsy, which was managed by partial modified NAPs. So as we all know, cranial nerve 3 palsies in children are often congenital and attributed to developmental anomalies or intrauterine or birth trauma, and the presenting features typically include unilateral ptosis, ophthalmoplegia and pupil involvement. Frequency of aberrant regeneration signs seen in these cases, such as pseudo-von-Graffi, inverse Duane sign, pseudo-Arrayal-Robertson pupil, and adduction on attempted up or down gaze, suggests that majority of the lesions occur along the peripheral nerve. However, central lesions have also been reported. And the differential diagnosis encompass monocular elevation deficit, acquired third nerve palsy, Duane's retraction syndrome, congenital Horner's syndrome, chronic progressive external ophthalmoplegia, and congenital fibrosis of extraocular muscles. My purpose is to present the surgical outcome of partial modified NAP surgery in a case of congenital third nerve palsy. So my patient here is an 11-year-old female from Telangana who had the chief complaints of drooping of left eye upper lid since birth, and also inability to move left eye since 3 years. She doesn't complain of any history of trauma to the left eye nor any other ocular symptoms or previous ocular surgeries. There was no significant birth history, family history and medical history. Personal history was normal. General examination was nil significant. On inspection, she had chin and brow elevation, and facial symmetry was lost due to left eye ptosis. Ocular symmetry was lost due to left eye ptosis and left eye exo and hypotropia. Anterior segment examination of the right eye was within normal limits and left eye showed ptosis and the pupil was round regular and reacting to light. Post-dilated examination was within normal limits in both eyes. Coming to the orthoptic evaluation, left eye showed 15-degree exo and hypotropia, and on alternate cover test, left eye moves in and up to take fixation, right eye moves down and out to take fixation. Prism bar cover test, a 30 PD prism, base in prism and 25 PD base up prism in left eye was kept to neutralize. Extraocular movement showed major limitation in elevation of left eye and also slight limitation in adduction. This is the 9-gaze picture. Sensory evaluation showed right dominance. And coming to the ptosis evaluation, palpebral fissure height was reduced and also there was poor Bell's phenomenon in left eye. Cranial nerve examination, all the cranial nerve was intact except for the cranial nerve 3 where there was elevation deficit, adduction deficit and poor LPS action. Both eye vision was 6/6, color vision both eyes 17/17, brightness right eye more than left eye and fields both eye normal by confrontation. There was signs of aberrant regeneration, which is the inverse Duane sign seen in this case, where there is increased palpebral fissure height on adduction. FDT was negative. Management was left eye 5 mm inferior rectus recession and also left eye partial modified NAPS procedure was done where left eye complete splitting of LR muscle was done. The lower half of the LR muscle 9 mm precision was done and the upper half was transposed to the SR muscle and augmented with Foster's augmentation suture. The post-op, there was significant improvement in the orthotropia and the pseudotosis components was reduced because of the orthotropia achieved. Also, we have taken pictures of the post-op 1 month and there was improvement in the compensatory head posture as well. So for ptosis management, we have given crutch glasses and the patient was advised to follow up. So basically NAPS or modified NAPS is done for monocular elevation deficit and it involves the horizontal rectus muscle being transposed to the SR muscle. But here we have tried it for congenital third nerve palsy and we have achieved orthotropia and also removed the pseudotosis. Yes,
move directly to the conclusion slide.
Patient has shown optimal functional outcome following the surgical procedure as tailored to the patient's magnitude of deviation and deficit. Thank you.
I have a query. You say that it is congenital third nerve palsy, but you also mentioned aberrant regeneration, right?
Yes, ma'am.
But what do you think is the plan of management in a case of aberrant regeneration? What is the literature about aberrant regeneration?
Ma'am, actually the other eye can be operated for left eye LR recession, ma'am. But the patient, she's a young child. There's already a stigma of getting operated for the abnormal eye. So
what was your observation about the post-operatively palpebral apertures? You said that the HP improved and that was apparent also. But what was your observation about the palpebral apertures? Because that is the only limitation when you operate a congenital a palsy case with aberrant regeneration. What was your observation about the palpebral aperture in the eye?
Ma'am, palpebral aperture actually because of the because of the elimination of the pseudotosis, because it's due to hypertropia, because of the orthotropia now, the palpebral aperture height is increased now, but not full ptosis correction was achieved because of the aberrant regeneration also. So we have given crutch glasses for now. The patient is being followed up now.
Anything else? So we'll
Thank you, ma'am.
move to the next. Has Dr. Shivani come? Dr. Shivani has come? No? Dr. Shivani is not yet there. So we take the next one.
Anupam Singh. Good evening on one and all.
This presentation is of Dr. Deepti, which is playing right now.
So there is discrepancy between this order and that program book. That's why this confusion has been occurred. I am going to present an atypical and unusual case of bilateral optic neuritis which happened and which was precipitated after strabismus surgery under general anesthesia. We all know squint surgery is common procedure and with high success rate, but rare complications like hemorrhage infections, tear rupture, slip muscle, lost muscle, and anterior segment ischemia syndrome. But in literature, very few neuro-ophthalmological complications have been reported, and one is that NION, which is reported after various other surgery as well, like cataract surgery, buccal surgery, pars plana vitrectomy, LASIK and all. And there is only one NION reported after squint surgery under general anesthesia. In this report, we are presenting a rare case incidence of bilateral optic neuritis which was precipitated just immediately, one day, first post-op day, after doing surgery under general anesthesia in a 15-year-old female. A 15-year-old girl having accommodative esotropia with B-pattern bilateral IO overaction was planned for squint surgery under GA. This is the preoperative 9-gauge photograph with showing a significant extorsion and fundus photographs. And best corrected visual acuity was 6 parts with refractive correction, and she was orthophoric as far as esotropia was concerned with refractive correction, but the surgery was done for bilateral eye erection and significant V pattern. That's why we did bilateral iodization under general anesthesia using agent propofol 60 mg, atracurium 30 and fentanyl 70 microgram. And patient was, all surgical event was uneventful. On the very first post-op day, patient developed acute onset of headache, vomiting and so many things, but we thought it was the withdrawal effect of general anesthesia and supportive treatment was given. But after 7th day, she again developed with severe headache and which was in bitemporal region, and she was experiencing blurring of vision as well. And otherwise there was no associated symptoms. The visual acuity was dropped and their pupillary reaction was, right eye was brisk but left eye RAPD was noted, contrast sensitivity was reduced, color vision was normal. And we witnessed the blurring of disc margin, which was not present preoperatively, bilateral blurring of disc margin, and patient, otherwise all neurological parameters were fine. And then we sent for pediatric neurology opinion and CSF analysis, all autoimmune investigations were done, we came to be normal. VAP was abnormal and increased latency bilateral, left more than right, and contrast enhanced MRI is highly suggestive of bilateral optic neuritis. And contrast enhanced MRI spine was normal, ruling out other demyelinating disorders. Then patient was given IVMP pulse therapy for 3 days and followed by oral prednisolone 40 mg OTN, which was tapered off over next 8 weeks. The second problem arise after giving steroid. Patient developed a steroid-induced glaucoma, and the IOP was after 2 weeks of therapy, IOP was 28 and 35, which was managed medically. Cup disc ratio was also increased. Here we can say the cup disc ratio increased as compared to preoperative fundus photograph. And she was kept on follow-up. Steroids were tapered over the anti-glaucoma agents with the undercover. Later on, everything was withdrawn. After 36 months of follow-up, she is maintaining orthophoria, no history of any recurrence of optic neuritis, and she is doing well. The only thing is NION is reported after strabismus surgery. This is the rarest of rare. There is no report we have witnessed having incidence of bilateral optic neuritis after general anesthesia. As we bilateral optic neuritis was idiopathic, but as patient just immediately after the GA incident she developed, we investigated everything, and we could not find direct association between the squint surgery otherwise, because a squint surgery was uneventful. Then we searched for a literature, which we found that there is potential link is reported between in females between 30 to 39 years of age group developing optic neuropathy with having given propofol as an anesthetic agent. However, trial did not provide has not provided the details and duration of the propofol. It is available on Google, and we cannot conclude that only single incidence of this can be directly linked to the GA agents, but this kind of incidence can be kept in mind, because number of times we see squint surgery ke baad these things are normal because of change in torsion and all. Sometimes patient can have real problems and optic neuritis, and this highlights another thing. Second thing which we want to highlight, when we are giving steroid, IOP should be measured, monitored.
Dr. Anupam, there's one question. Do you think, did you investigate her for viral illness or not?
Everything.
Viral illness, like pre-existing little sinusitis or...
Nothing was available, everything was done, and the proper workup was done, and then treatment was given under supervision of pediatric
And one of the common etiology is idiopathic also.
Yeah.
So, means...
It was
yeah.
idiopathic bilateral optic neuritis according to the investigation, but it happens just immediately after GA, and we got the link in literature as well, that propofol has led to this kind of incidents. But otherwise, after squint surgery, we have not witnessed. And we cannot... idiopathic में recurrence का भी है ना अभी
that's what means there is a strong association after strabismus surgery or something like that.
Strabismus surgery was absolutely fine. It most probably if it otherwise it happened because of GA and anesthetic agent, propofol most of.
Any other drugs causing an AION?
No idea, sir. Thank you.
Documentous changes, did it recover?
Yes, sir, she has recovered fully, but the
changes-
glaucoma, these changes still she is having 0.7, 0.6 and 0.7 cup. It has reduced by 1, but this changes is persisting. Increased cup this ratio is still persisting.
And what about the fields?
Fields could not be done because of the data parameters. She is 15, 16-year-old. So we could not do that. Otherwise, visuality, color vision, contrast sensitivity, everything is normal.
Yeah, but there's one question that pre-existing, what was the status of optic disc pre?
वो सर pre-operative मैम photograph है normal था बिल्कुल.
Absolutely normal, and
Yeah, वो दिखाया था
it went to 0.6, 0.7 in a short time.
Yes, because of after having
Even,
steroid treatment only. We have pre-operative photographs. I have shown in first line. Absolutely 0.223 cup. RNFL, ma'am, we don't have parameters pediatric, no, so we could not do RNFL.
So total progress was in how much time? Means this
She
cupping.
recovered within 8 to 10 weeks. But we were worried for the glaucoma, and when they pediatric neurologists recommend slow tapering of oral steroid to prevent recurrence in pediatric age group. So slow tapering led to the glaucoma, and in that we were more worried for the glaucoma part, because every time her IOP was raised, so we had to give acetazolamide and maximum glaucoma therapy it required to recover. But this ratio is still
Any family history?
no family history, sir. We have worked up properly. Thank you, sir.
Dr. Shivani.
Good evening, everyone. So I'm going to present today the two interesting cases of monocular elevation deficit. So the purpose is to present these two different cases. Case 1 was a 11-year-old girl who presented with a downward deviation of right eye since birth. The best corrected visual acuity in this eye was 20/800 and the left eye was normal, that is 20/20. The Hirschberg test showed marked hypotropia. You can see in this picture that the right eye shows marked hypotropia. Even on Hirschberg, we can see it is more than 45 degrees of hypotropia with a limitation in elevation in the right eye of -3 to -4. Ocular motility and eye was normal in the left eye. Modified Krimsky's test showed more than 50% diopter of hypotropia in the right eye, and rest of all examination, intraocular examination, slit lamp, pupil and fundus examination was normal in this child. So you can see that in the central picture the patient shows hypotropia, and in elevation there is marked limitation of elevation in the picture. A provisional diagnosis of monocular elevation deficit of right eye was made, and neurological imaging was done, which was found to be normal. Force reduction test was done, in which inferior rectus was found to be tight. Hence, a staged procedure of inferior rectus followed by an augmented naps procedure was planned for this patient. So, post IR recession, there was no change in hypotropia. The patient remained the same in the primary gaze. However, there was slight improvement in the elevation of the right eye. Then the second surgery, that is augmented naps, was done. That is transposition of the horizontal recti to the adjacent to the superior rectus, preserving the spiral of Tilloch's. Augmented, that is the standard naps, and augmented naps means posterior fixation suture was placed in the sclera, 8 mm posterior to the insertion of the superior rectus, and the lateral borders and the medial borders of the superior rectus was hitched with the transposed horizontal recti muscles. So this is after the augmented naps. This is a post-op day 3 picture, the first picture. Second is the post-op 3-month picture. In primary gaze, patient is maintaining a good orthophoria, and there is improvement in elevation also. Second case is a 7-year-old girl who presented with drooping of upper lid of the right eye since birth. In this case, the patient did not have amblyopia. As we see that the first case, the child had amblyopia. This case, the best corrected visual acuity in the right eye was 20/30, in the left eye was 20/20. Hirschberg test showed hypotropia along with marked limitation and elevation in the right eye. The ocular motility of left eye was normal. The prism bar cover test showed 60 PD of hypotropia in the right eye, along with mild exophoria. The Bell's phenomenon was poor. Since she had ptosis also, there was Marcus gun phenomenon present, and rest all examination was normal. So you can see that the first picture, right upper lid severe ptosis is seen along with hypotropia, and also note the unmasked component of pseudotosis when the right eye is made to fix. So this is the child in primary gaze showing hypotropia of around 60 PD, 30 degrees is seen on Hirschberg, and a limitation of upgaze. So monocular elevation deficit with severe ptosis of the right eye along with pseudotosis component with poor Bell's and MGP. Neuroimaging was normal, ability was found to be tight for inferior rectus, and a surgical plan of. In the previous case, we did a staged procedure. In this, we did a single sitting procedure, that is inferior rectus recession, along with a modified Nishida's procedure to correct the ocular alignment, and then a second stage procedure for managing the ptosis. So modified Nishida's procedure, in this a radial conjunctival incision is made in the supratemporal and the supranasal quadrant, and a non-absorbable polyester suture is woven through the superior 1/3 of the horizontal rectus muscles, 10 mm behind the insertion. The same suture is placed through a scleral bite, which is 12 mm behind the limbus in the midway between the superior rectus and the horizontal recti. The suture bite then transposes the horizontal recti and forces superiorly. So these are the intra pictures of the modified Nishida's procedure. So post Squint surgery, the patient, look at the primary gaze picture, the patient is maintaining orthophoria with improvement in the ocular motility in elevation. So this is after the second surgery, that is also ptosis correction, which we did by doing a silicone rod sling surgery. So the patient had a residual hypotrophy around 8 PD, and the exophoria still remained with a good ptosis correction. So these are the first case. Look at the pre and post-op picture, and this is the second case. So this treatment of MED can be variable, but the treatment of choice depends upon whether the FDT for IR is tight or is free. If the IR is tight, it needs to be recessed. Depending upon what procedure you need to do, you will, depending upon the amount of hypertropia, so it is whether
Let's move to the conclusion slide.
Ma'am, just
Time
this
is
is the
over.
last, almost the last
This
slide.
is the last slide?
Yes,
This
ma'am.
is the conclusion slide?
This is the last slide, next slide. So we, according to the amount of hypertrophy, we plan the procedure. These are the two procedures which we have discussed for large angle of hypertropia. So when you have a large angle of hypertropia, you can decide whether if you have a tight IR, and you can go with two-stage procedure. If it is large angle more than 60 PD, then you can do a two-stage procedure. If it is less than 60 PD, you can do a single-stage procedure. So advantage of modified Nishida is that we can do an IR recession along in the same sitting as the modified Nishida's procedure, and it is reversible also. So these are two good options for large angle monocular elevation deficit. Thank you.
Did you find any difficulty with near vision
After doing the surgery,
after
sir? Sir, no, my first patient was amblyopic.
first case?
No, sir, no problem with near vision. No problem. So actually the child was already amblyopic, so she was not appreciating much with the right eye. So her vision, she did not complain about any problem.
The picture was showing there is disparity between one and the
Slight exophoria post-surgery because of probably the imbalance between the recti muscles, horizontal recti.
Thank you.
Thank you, thanks so much.
I think Shivani is not. No, one is there, Dr. Dipti. So we call upon Dr. Dipti for ocular motility disturbances after scleral buckle surgery, double trouble.
Good evening everyone. Presenting my paper on ocular motility disturbances after a scleral buckle surgery, double trouble. I have nil financial disclosure. Following a scleral buckle surgery, nearly 50% of the patients develop transient strabismus, which remains persistent in about 5 to 25% of the patients. The major etiology ranges from restrictive adhesions, muscle damage to sensory deviations. Because of these varied etiology, the treatment of these type of strabismus is also variable. Hence, through this study, we would like to describe clinical features, management protocols, and the outcomes of different management protocols in patient with strabismus post-scleral buckle. Totally 19 patients were included who had persistent diplopia and tropia after a scleral buckle surgery. Any foveal pathology were excluded from the study criteria. Thorough strabismus evaluation, including primary, secondary, and extraocular movements, were assessed. Type of the management, and if surgery done, what was the surgical technique used, and for the outcomes, sensory and the motor assessment was done. A horizontal deviation of less than 10 prism diopter and a vertical deviation of less than 4 prism diopter and no diplopia in primary position was considered as the criteria for success. Of the 19 patients, 14 were male and the mean age was 39 years. Nearly 52% of the patients had vision about 6 by 18 to 6 by 36, 2 had less than 6 by 60, and 7 had a good vision of 6 by 6 to 6 by 12 despite buckle. Strabismus was most commonly seen in those patients in whom more than 2 segmental scleral buckle was used or who had underwent recurrent buckling surgery, which was statistically significant. Horizontal type of strabismus was noted in 63%, but in about the rest 40% vertical and mixed type of strabismus was also noted. 2 patients were treated with prisms, 2 patients underwent botulinum toxin injection, and 15 patients were managed surgically. There was no significant statistical outcome deviation between these 3 groups. Of the 2 patients who underwent prism, they had deviation less than 12 prism diopter with normal extraocular movements. Post deviation, they were orthophoric. Those who had deviation more than prism range and still the ocular movements were normal were given a trial of botulinum toxin in 2 patients. They had esotropia. An injection of botulinum toxin into medial rectus muscle made them orthophoric, and an outcome of 2 PD, successful outcome noted. In the surgical group, there were totally 15 patients. 4 had extraocular movement restriction. The buccal was removed only in 2 patients who had exposure and infection. 10 underwent conventional recession, 3 patients had hangback recession, and 1 underwent each adjustable recession and muzzle transposition. 2 patients had severe conjunctival fibrosis and an amniotic membrane transplantation was done at the end. This is a patient who had hypertropia, underwent a conventional SR recession, the patient with exotropia who underwent adjustable lateral rectus recession, and this is the patient who had the buccal infection removed, following which there was IR was severely damaged and IO muscle transposition was done as IR couldn't be retrieved. So through previous studies, we know that horizontal strabismus is most common after scleral buckle and mostly seen after repeat buckling surgery, and for treatment, previous studies advocate buccal removal. What new did we find in our study was, even though 64% of the patients had horizontal strabismus, nearly 37% had vertical and mixed strabismus too. It is the site of the buccal which is determinant for the development of strabismus. Management decision has to be done based on extraocular movement. If it is full with good fusion, prism or botulinum toxin can be tried, but a restricted or sensory type of strabismus surgery has to be tried. Only in complicated cases buccal removal has to be done, else by modifying our squint surgery with extensive careful dissection using antifibrotic agents like mitomycin and amniotic membrane, or specialized technique like adjustable or hangback techniques, we can still retain buccal in most of these patients with strabismus. So with all these maneuvers, strabismus surgery in a post-buccal patients is a owner's envy but a neighbor's pride, that is we strabismologists' pride. These are my references. Thank you.
Okay, why do you think that some cases develop strabismus after?
Sir, it depends.
Same site of scleral buckle, but some cases develop. It is not only the site but the tightness and direct
muscle damage, as well as when they are giving peribulbar anesthesia, that could also be one of the factor. And two, tightness of the buccal can actually cause a extensive fibrosis of the muscle, because they first put the encircling band and over that they put the buccal. So with those two things sitting at a place, if it's very tight, mostly the inferior rectus muscle immediately undergoes the fibrosis part. So that is one more. If there is fibrosis, we have to release that muscle rather than doing the contralateral plication. It doesn't work much.
Okay, thank you.
Thank you, thank you, sir.
Dr. Shivani is not yet there, so we close. Here or they have left the hall? The participants are still here. I can identify two. Or anybody else who's here? We can take a